started here.
Okay. Dr. Freese is a board-certified radiation oncologist. He completed his undergraduate studies at The Ohio University and completed medical school at the University of Cincinnati College of Medicine. Dr. Freese holds several professional memberships, including American Society for Radiation Oncology, the American College of Radiology, the American Radiation Society, and the American Medical Association. Thank you, Dr. Freese.
And thank you, Dr. Freese.
Yeah, thank you guys so much for letting me talk tonight. And I'm really excited to help out in any way I can. So yeah, once again, I'm Chris Freese from Cincinnati, born and raised. And this talk tonight, I really want to try to keep it an open discussion. So obviously, I want you guys to get as much out of this as you can. And my big pitch I always make, I want to say outright is, once again, I'm not here to sell you. I love radiation oncology, which is obviously we'll have a radiation oncologist. But I think what's obviously very important to you guys is that you feel comfortable with whatever choice you pick, no matter who it's with, and really just trying to do whatever you can to help better your disease control and also quality of life. So my talk really is going to focus on a few questions that were posed before all this, before the meeting, and then I want to leave the bulk of the time really just for question and answers and whatever I can do to help out. So to kick things off, so really, yeah, once again, go through the 4 questions and try to keep things open-ended, though, on the back end. So first question, and I feel like this is one of the more common ones we always get, is radiation or surgery? And that's a huge, loaded question, and there's a lot that goes into it. And I think really the big picture is they're both equal. No matter what you pick, there's no difference in outcomes between surgery and radiation. The guidelines support that as well. So with oncology or cancer in general, the kind of benchmark for all cancer care in the U.S. is something called the NCCN guidelines. And that is really what is used by providers nationwide to ensure that they're providing the most up-to-date level of care for a disease site. And when you look at really any kind of stage for stage, with some exceptions, but really stage for stage for prostate cancer, surgery and radiation are really equal. And there's actually really never been a big randomized trial to compare one head-to-head, and a lot of that's because a lot of the studies show that there's really no big difference in outcomes. One of the more recent trials that indirectly compared them was one done out of the UK, where they actually were looking at men with mostly low-risk prostate cancer, but some intermediate, and they looked at doing actually observation or active surveillance versus treatment, and treatment was either surgery or radiation. And it was really dealer's choice based on the patient. And interestingly, at the end of 10 years, I think the big takeaway from that is that there was no difference in outcomes. Patients, treatment-wise, surgery, radiation, no difference. So both equal. The big disclaimers I have for kind of, okay, so if they're all equal, is there really a situation where certain folks are handled better with surgery or radiation? My take is that usually younger folks in their 50s or early 60s, otherwise healthy, I do think that, once again, both radiation and surgery are fine to choose. The younger folks in their 50s, I tend to potentially push toward surgery. A lot of that's because their life expectancy is fairly long, and I think if they may be better served with a surgical resection as opposed to radiation, but there's, once again, no randomized trial to say that you can't do it in younger folks, and we do definitely do it in folks who are in their 50s. So that's one caveat. Other folks too, if you have really bad obstructive symptoms, so people who are peeing all day, peeing all night, having trouble urinating, prior history of catheterizations, all things being equal, those guys would better be served with surgery as well. Just because if they have such bad obstructive symptoms, radiation is not going to improve that. So those are guys definitely who are better served with a resection to kind of remove the kink in the hose, so to speak. But yeah, and overall, though, I hope that kind of clears some things up, though. But really, what I always tell patients when they meet with me for radiation is, at the end of the day, both options are great. If you pick surgery, that's a terrific way to go. Great outcomes. Radiation, they're the same. And whatever helps the patient sleep best at night, whatever they feel most comfortable choosing, that's the right answer. Because you never want to look back and say, woulda, coulda, shoulda. Because once again, you're not wrong. Both are great, and you can't go wrong with either option. I talk fast and I talk a lot, so I apologize. I just want to check to see the chat if I missed anything. do I exit out of this? The meeting controls. All right, we'll go on to the next. I tried to pull up the, and I apologize, I'm trying to see if I can find the chat screen. I can't see that yet. Okay, just making sure I'm not missing anything. All right, so next big question. So types of radiation. There's really many different types out there. A lot of it, the confusion is because back in the old days, I don't want to say old days, but not too long ago, 10 years ago, most folks received what's called conventional radiation, which is daily, Monday through Friday, 5 days a week for 7 to 8 weeks. And more recently, there's been a few big trials, a couple here in the US and multiple done in Europe, where they said, okay, if radiation outcomes are good at 8+ weeks, can we shorten the treatment and still provide the same side effect profile, same outcomes, same quality care for patients? And they showed you can. So in Europe, there's been a couple big trials that looked at comparing a little over 6 to 7 weeks of treatment to 4 weeks of treatment, and they were shown to be equal at 10 years. And in the US, they did a similar trial where they looked at doing a little over 5 weeks compared to your classic 8+ week treatment. And once again, equal, no difference in outcomes, no difference in side effects. So the new trend in the US or worldwide is to really shorten up the treatments and do essentially anywhere from 5 to 4 weeks. There's also another type of radiation out there as far as fractionation goes called SBRT, you've probably heard of, which is a 5 treatment course, which is once again usually every other day or twice a week for anywhere from 2 to 3 weeks. And it's just a higher dose per day, but less treatments. There's a few trials. One actually just finished accruing in the US, trying to compare that to regular fractionated, or actually a 4-week course of radiation or a 5-week course. So we're hoping to have some big randomized trials come out here soon to show that they're relatively equal. But we have good data though, and there's already a lot of great data over 10, 15 years, if not longer, showing that SBRT is safe and presumably equal to all other courses of radiation. There's nothing to say that it's not. So I think all things being said, the guidelines support it, that SBRT or hypofractionated or conventionally fractionated are all great choices. They're all absolutely the same. A lot of it's really just patient preference as well as care provider preference, whatever they're kind of more used to doing overall. But once again, they're equal, no difference. There's other things too, and I know that gets even more confusing. There's something called brachytherapy, which is also a great option of therapy, which is seeds, or there's actually even a type of brachytherapy using needles. And there's also combinations of brachytherapy with external beam or brachytherapy with hypofractionated or the shorter course of radiation. So there's truly 1,000,001 ways to skin a cat. For the most part, all different modalities are the same. And it really is just patient choice as far as what they think would best suit them and what they want to go through. This was a great question, and actually I had a patient ask that not too long ago. So there's a lot of different new imaging studies coming out in the US. One more recent one that was approved is called a PSA PET scan. It's a terrific study that we're often using now in people with biochemical recurrence, where it will actually localize and allow you to really pinpoint where the prostate cancer is at. And in men with high-risk disease, the big question always comes up, in men who have high-risk disease, who we often tend to treat with whole pelvic radiation, in addition to just to treating the prostate, the question is, well, if they get a PSMA PET scan, which is negative, do we still need to do the whole pelvis radiation? And that's an excellent question, and I don't want to get in the weeds too much because this is a very nuanced, debated question, and really it's almost like Democrats and Republicans, where you can go around the country and find different camps of people who believe in whole pelvic radiation or not in prostate cancer. But in general, just to summarize things, in men with low risk or intermediate risk, we treat prostate alone with radiation. No matter what type you get, you do prostate alone. In men with higher risk disease, there are classically some people who would treat lymph nodes in addition to the prostate, and other folks who would treat prostate alone. Overall, the debate is because there's not been a randomized trial to show what's called an overall survival benefit, whole pelvis versus prostate alone in men with high risk disease. There is some studies to show, though, that there is an improvement in what we call disease-specific survival or biochemical control. So that I do think there is likely a benefit. That is the trend with men with higher risk disease. We often do it. But I think the naysayers say, well, okay, that's all great and good, but you're not making these men overall live longer. So that's still kind of a debated topic. But I think, though, to kind of highlight big things, the guidelines do talk about on NCCN, for example, that men with high risk disease, they do recommend that you strongly consider doing whole pelvis, because if you are improving biochemical control, you're potentially preventing them from going on to further therapy or if they have recurrent disease or kind of longer courses of hormone therapy. But big picture, PSMA PET. So if you get a PSMA PET, do you still need to do whole pelvis if it's negative? And we don't have a great answer to that yet. The one thing, though, there was a great study that came out. This is the highlight of it here, or the title of it. But interestingly, it's actually done out of India, but it's the best study we have. It's in JCO. It's supported. It's quoted by a lot of people, but they looked at men with high-risk disease and said, okay, prostate versus whole pelvis with prostate, who does better? And once again, no benefit in overall survival, but they showed an improvement in biochemical or PSA control, as well as an improvement in disease-specific survival, meaning the odds you die from your cancer. So overall, it was a positive study, and I think people do support the use of whole pelvis. But what's interesting, up to 80% of the men on this trial had a PSMA PET before they underwent treatment. So these are all guys, presumably, with node negative through the most thorough imaging we have, but still had a benefit from whole pelvic radiation. So I think even though PSMA is a great new tool, the trend is still, even if you have a negative PSMA, to still do whole pelvic radiation. And sorry, that's a very nuts and boltsy discussion. And really, it's very nuanced, but still a lot of people talk about it. The last big question I have, or I was asked is, okay, so why Christ? And so like I said before, I hate to, in medicine, it always feels very dirty to kind of, I hate to feel like you're trying to sell or do a business. I think we're all here to care for patients. And my take is Christ is full of a lot of terrific, excellent doctors. We have a lot of great care providers, a lot of great services, including care pathways, navigators, a lot of great technicians and trials as well that we can offer to patients. And I always tell folks whenever they come to meet with me that my job as a provider, as a doctor, first and foremost is, one, to give them information. And I think at the end of the day, the patient's the boss. They're in the driver's seat. Whatever they want to do, whatever they're most comfortable with, I support that, and I will do whatever I can to make sure that they are informed and also have whatever tools they need to make the decision for their cancer. And there's a lot of great doctors in the city, at other institutions, including UC and St. Elizabeth. So really, I think that the most important thing as a patient is that you are comfortable with your doctor and feel that you are have a good relationship, so you are comfortable then to go forward with treatment. So cancer is a team sport. There's a lot of great players out there. At the end of the day, I think just pick whoever you feel comfortable with. I would love for you to come to Christ. I think we have a great team, but also, once again, I think that you have to find someone that you are comfortable going forward with therapy with. That's my political way to say that truly you're not wrong in choosing whoever you feel you're best with. So that's my spiel. And so yeah, I really wanted to open up to, first of all, any questions about anything that I've said so far, or any I can clarify. Let me see if I can find the chat.
I have not had any questions through the chat yet.
Dr. Freese, I had a question about your comment that when you were talking surgery versus radiation.
Yeah, yep.
Said men in their 50s, you normally would recommend surgery. But I'm not clear why surgery versus radiation at a younger age.
Yeah, this is a terrific question. So now, once again, this is not based off randomized data. This is not based off randomized trials. So there really is nothing to say that you cannot treat a younger patient with radiation, and you can still go to many institutions around the country and they will still offer you. And once again, I've treated folks in their 50s, and that's not wrong if patients are interested. I think the one thing that I always mention is, so you've probably heard of folks who get surgery potentially can get salvage radiation if they recur. And you've probably heard often folks talk about, well, if you get radiation, we're often told that we cannot get therapy or surgery after. I don't want to delve into that too much because we do local therapy now for men who have recurrent local disease and radiation. Often that's either cryotherapy or brachytherapy or other local treatments. So that's not off the table. But still, men can get radiation once again if they get surgery. There's been a few randomized trials looking at the role of adjuvant or what we call salvage radiation in men who have recurrent prostate cancer after they've had surgery. Overall, there is a benefit as far as what we call biochemical control, meaning if you get surgery and your PSA recurs, we know that there's a better chance, all things being equal, of your PSA being salvaged or controlled a second time with radiation. The trials are mixed as far as does that make you live longer? Meaning, okay, we're controlling your PSA, but are you going to live more years compared to if you did not get radiation and just got standard routine monitoring or hormone therapy down the road? And once again, there's some studies show that there's probably survival benefit. There's some that are mixed and don't show a benefit. I think, though, in men who are younger, in their 50s or younger, obviously, if you get surgery and you recur and you're not metastatic and it's just a PSA-only recurrence, if you then get salvage radiation, I definitely think there's a very strong argument that if you control that PSA, you presumably are going to make them live longer. And a lot of that, I think, is because with prostate cancer, the nature of the disease is that it's very slow growing. Men have to live usually many years before it becomes a problem if they recur, or in general, the disease process is slow. So for men to have a benefit from treatment, you obviously want them to live a long time to kind of fulfill the benefit and I guess make the juice worth the squeeze, so to speak, as far as side effects from the therapy. So I think in young men, though, where we presumably expect them to live a very long time, those are the guys who, when you're looking at salvage radiation, probably benefit the most. Does that answer your question? I know it's a very long-winded way of saying that I think the benefit of salvage therapy is better and a stronger argument in men who are younger.
Yeah, that's helpful. Thank you.
Absolutely.
I have two questions that have come through chat. The first one, I had my prostate removed 9 years ago. I had salvage radiation after my PSA rose. After my PSA was rising again, I opted for is it Axumin PET
Yep.
scan
Yeah.
that showed node activity. In a second opinion with Cleveland Clinic, they recommended doing focused radiation on the lymph nodes in parallel with 6 months of ADT based on results of a recent study. My radiologist in Cincinnati agreed to do this. I'm still waiting to see the results with the 6-month PSA. He indicated if the PSA rises again, we would likely go through the same process again. Your opinion of this process?
Yeah, I mean, great question. So I don't know, obviously, all the ins and outs of your case in general. Presumably, this is what we call oligometastatic recurrence. So in the big buzzword of all oncology is what's called oligometastatic disease. What that really means is, so when you have cancer, I don't want to get too in the weeds, but when you talk about it spreading, obviously disease, so cancer in general is a normal cell. So it's a cell that you have that's a normal healthy cell that at some point decided to become immortal. So all the cells in your body have an expiration date. After a couple of weeks of life, they die off and replaced. A cancer cell is a cell that has jumped on the line and says, the heck with that, I'm going to live forever. So it makes a deal with the devil, it mutates, it grows uncontrollably, and at some point that cancer will grow, or that tumor, it will go to a point where it needs to search out new food and find a greener pasture. So it will spread outside, for example, to lymph nodes or distant mets. That's really what cancer is. And when you look at cancer, once it's spread outside either the regional lymph nodes or in a distant site, we call it metastatic. And classically, those patients are not curable, and we tend to treat them with chemotherapy or hormone therapy alone, and in some cases use radiation to help slow things down or for symptom control. And not too long ago, there were some theories that came about that said, okay, not all cases of metastatic disease are created equal. There are these certain diseases or metastatic cases where the biology is different and it's more focused, meaning the disease does not shower all over, It only goes to a few sites, sets up shop, and that's it. And obviously, in theory, if you can find out which patients only spread to a few sites and treat them focally and treat every metastatic site, the moonshot is that you would cure these patients, if not at least provide them with what's called durable control. And there's been a few trials that have accrued where we're trying to randomize patients and trying to find out, is this true? Do patients have a benefit? And one big famous one was called Saber Comet, which came out showing that in men with, or patients with oligometastatic cancer, meaning usually 5 or less tumor sites, if you aggressively treat all those 5 metastatic sites, you potentially can make them live longer. And the working theory is that that's true. So I think that in oncology, there's been a big trend for men with limited metastatic disease that we are now trying to ablate or treat their sites of recurrence. So I think that, once again, I don't know all the details to your case particularly, or for example, even where it is in relation to your old radiation field, but I don't think it's wrong to do stuff like that. And I think that is the new big movement in oncology, is trying to treat or ablate all these sites if there's minimal recurrences outside of the normal region of disease. And NCCN supports that. So actually, NCCN guidelines, even for men with prostate cancer, they recommend consideration of SBRT or any focal ablative therapy in men with limited metastatic disease.
Okay, we've gotten some other questions that have come through. Next question. Discussion of best treatment options for men currently receiving ADT, Eligard, and best treatment option when ADT is no longer effective. I've been receiving 3-month Eligard injections for the last 2.5 years when my prostate cancer returned after my prostatectomy. Is anything besides Eligard recommended for me now, and what will be the best treatment when Eligard stops working?
Yeah, that's a great question. So, and a lot of this too depends on, once again, confirming that there's no metastatic disease or things like that with imaging, but all things being equal, just a PSA rise that's no longer responding to hormone therapy. There's lots of new tools out there. So sometimes we kind of double down on the hormone therapy, meaning adding on 2 different types of androgen deprivation drugs, the kind of dual blockade. There's also these other newer targeted medications such as abiraterone, enzalutamide, apalutamide, which are kind of these second-generation prostate cancer drugs that are showing great promise in men who are now castrate-resistant to their disease. Other things too, they're patients who are chemotherapy is one thing we hold in our back pocket, but docetaxel is always an option in the future too if things were to grow or progress. But yeah, there's lots of other drugs out there that are now being used in men with castrate-resistant hormone therapy. So often what I recommend men do is that if they're no longer responding to hormone therapy, is discuss with the medical oncologist. I often will refer folks to a medical oncologist to discuss what other next steps are out there to then try to kind of rein things back in and get a hold of that PSA. But yeah, there's lots of new drugs and lots of good promising options for folks with that type of disease.
Okay, next question. What is the timetable for the availability of PSMA scans in Cincinnati? What is the timetable, if any, for the availability of, is this luteum?
Yeah, lutetium.
Okay, 177
Yep.
PSMA therapy in this region of the country. So that and the PSMA scans.
Yeah, great question. So PSMA is already here. We actually have it at Christ this month. It's at UC. I believe it's at Jewish. It's also at the VA hospital, I believe. So it's pretty widely available in Cincinnati. We've already had a lot of patients obtain these scans, so definitely available in the city. Lutetium is another great new drug. It's a radio-labeled medication that is used to treat men with metastatic prostate cancer. And I believe at this time it is available at OSU. So definitely we've had folks go up there and receive lutetium. That's a great question. We actually talked about that this morning, trying to then now bring it here to Cincinnati. I do not know if they offer it at UC, but we are, I know in the process we've discussed at least trying to ask around and see if we can offer that here at Christ. But as far as I know, I believe the closest is OSU, and they are offering lutetium in men who have refractory metastatic disease.
Okay, next question. I'm probably going to mess this up a little bit, but what numbers should we be regularly monitoring for possible biochemical recurrence? At what point should we consider the numbers we're monitoring warrant follow-up treatment? Some say to use 2 ng/ml above nadir. Am I saying that right?
Yeah, yep.
Others say to use PSA doubling time and other patient-specific factors because biochemical occurrence often occurs before the 2 ng/ml threshold is reached. There's a little bit more to this question. Do you want me to stop there and then keep going?
That's fine. Yeah, so great question. It depends on the type of therapy you had. So in folks who've had surgery, the classic answer is a biochemical recurrence is 0.2 or above. In reality, if there's a positive PSA after surgery or a persistently positive PSA, presumably that is residual cancer that's left behind, so they're recurrent. But in general, the classic answer is 0.2 or above is your threshold for failure. Radiation's a little bit different. The classic number is, like you mentioned, 2 or above the nadir. So meaning if you bottom out at 0.5, and that's your steady spot, at some point if you then rise above that, we often want folks to get above 2.5 before we call it a true failure. A lot of that's because in men who get radiation therapy alone, the odds your PSA is undetectable long-term is roughly 30-40%, potentially actually even less. So most men will have a detectable PSA, but it's low. Ideally less than 1, but often it's detectable but low. The thinking is some normal prostate tissue survive the treatment, so you'll always possibly have some detectable PSA. But once again, in general, external beam, about 30 plus or minus % of men will have an undetectable. Most of the times it's low and stays low. It can take about up to a year to 2 years for men to reach their nadir, meaning that lowest point. And then the trend is what you follow. We do have this phenomenon in prostate cancer in men who've had radiation called a bounce, a PSA bounce. And that is actually a PSA that rises temporarily. And so often we put the threshold at a 2 or above because men can, if they're followed over a long period of time, who have a detectable PSA, it can kind of go up and down every once in a while. So we don't get too worked up unless it persistently rises. That trend continues to go up. That's where you get worried.
Okay, next question, and there are still maybe 4 others in here. Which PSMA PET scan provides better results? Elux6, PSMA 11, or Pylarify? Sorry.
Yeah, great question. I think a lot of them mostly just brand names, so they're all the same. PSMA PET scans. So if, for example, in the city, a lot of them all come from the same actually source. But around the country, it's regulated, so the study should be the same. I always tell folks, get whatever's closest to you. That's the best way to go.
Okay, we read that radiation treatments sometimes result in secondary cancers. Is the chances of secondary cancers different or the same between IMRT, SBRT, and proton therapies?
No, it's all the same. Yeah, it's all the exact same. I always tell folks the classic answer for that is 2% at 20 years. So if you are 70 years of age, when you are 90, your risk of a cancer from the radiation is 2%. Obviously, you're at presumably a much higher risk of your cancer recurring compared to that, but in general, that's what it is. That's also another argument for men who are younger. So in the folks who are in their 50s or younger, it's not wrong to say, okay, well, if it's 2% when they're 70, if they're 50, then if you think, oh gosh, they have another 20, 30 years, what will that number be? And I think that if you are in your early 50s or, gosh, God forbid, in your 40s with prostate cancer, I think that it's not wrong to say, okay, well, they are at a higher risk of a cancer from the radiation if you follow them out 40 years. But yes, that's the classic number. But yeah, it doesn't matter what type of radiation you get. It's all the same.
2 other questions in here for now. Feel free to put in the chat other questions if you have them. We hear more and more about the use of radiation and ultrasound being used to treat BPH. Systems like TULSA-PRO and focal laser ablation are being repurposed to handle this problem. What are your thoughts for this type of treatment for BPH?
Yeah, that's an excellent question. So I do not know too much about the actual specific radiation side related to BPH. I have heard, I know folks doing anything from HIFU to prostatic artery embolization, various things that are really doing excellent work, I think, in improving people's symptoms related to that. But as far as the radiation goes, I do not know of the data to support, like specifically like brachytherapy, for example, or IMRT, and I've not heard of that used yet. But yeah, I think definitely HIFU or different things in that realm that treat BPH is absolutely fine, and folks use it a lot.
Okay, last question in here for now. What is the average life expectancy of men with castration-resistant prostate cancer?
Yeah, gosh, that's a very loaded ending question. Usually it depends. I mean, it depends, one, if the patient's metastatic. It depends if the disease is still just undetectable and biochemically recurrent. So it's variable. But it can be anywhere from a few, usually a couple years. But once again, I think that's in men with metastatic castrate-resistant prostate cancer who are failing other therapies. Usually it's a couple years. But if it's biochemically recurrent without any evidence of metastatic disease, presumably longer because things are still slower to progress.
Okay, that's all the questions in the chat for now.
Yeah, and so one tough thing I always tell patients with prostate cancer is there is so much information out there regarding prostate cancer. You can just basically type in prostate in your Google search bar, hit enter, and you're going to roll through 1,000,001 different advertisements or people talking about miracle cures or this, that, and the other thing between, you name it. There's a million treatments out there. I always tell patients that the first thing you should always do is, one, obviously educate yourself. Look for good quality sources. NCCN is a great one. There's also something called rtanswers.org, which is a great, excellent resource for radiation information. But really try to find reputable resources, things that aren't selling you, things that are just giving you info. And really, too, the reason there's so many options out there is because, once again, there's not been a trial to say one's better than the other. If you have any other cancer, for example, lung cancer or head neck cancer or, gosh, things like that, you come see a doctor, often based on your stage, the type of disease you have, there's really one treatment, and that's what you shoot for cure. Prostate, there's not that. There's so many options out there. All are really equal. It's a curse where I always tell patients it's great you have 1,000,001 options. It's bad you have 1,000,001 options. So you got to choose kind of what is best for you. But I think the fact that you have that freedom to pick what you feel best suits your lifestyle, what best suits your beliefs is excellent. And so really, you're not wrong whatever option you choose, but it's just really important to educate yourself and feel comfortable with whatever you pick. But you're not wrong in choosing any real option in most scenarios.
No other questions in the chat.